Welcome to Physician Focus. I'm Dr. Barbara Herbert, Medical Director of Addiction Service at Commonwealth Care Alliance and President-elect of the Massachusetts chapter of the American Society of Addiction Medicine, and your host for this edition of our program. The abuse of opioids and prescription drugs has become a national public health problem here in Massachusetts and across the United States. Many efforts have been and continue to be undertaken by government officials and health providers to reduce the problem, with varying results. At the same time, many patients are experiencing chronic pain, and patients, physicians, and other providers are concerned that overreaction may deprive patients of needed medications. This edition of Physician Focus will examine the physician's perspective of prescription pain medicines and prescription drug abuse. Among our topics will be the responsibilities of physicians in writing prescriptions, how we balance the alleviation of pain and the risks of addiction, and the role and responsibility of our patients in using prescription drugs. With me for our discussion are Dr. Richard Peters and Dr. Daniel Alford. Dr. Peters is a radiation oncologist at the University of Massachusetts Memorial Medical Center in Worcester and is the 2014-2015 president of the Massachusetts Medical Society, our statewide association of physicians. He is board certified in both radiation oncology and hospice and palliative medicine. Dr. Alford is a general internist, primary care physician who is board certified in addiction medicine. He is the director of the Safe and Competent Opioid Prescribing Education Program at Boston University School of Medicine, and the director of the Clinical Addiction Research and Education Unit at Boston Medical Center. He is also the recipient of the 2014 American Medical Association Foundation Health Education Award for his efforts in the field of prescription opioid drug safety. Welcome.
Glad to be here.
Glad to be here, thanks.
I think we should start by trying to really define the issue. Dan, what do you really think are the causes of this problem?
I think there are lots of causes. I think, as you had mentioned, chronic pain is common. It's estimated that 100 million people in this country suffer from chronic pain. And those patients expect to get treated. And I think there's been an over-reliance on prescription opioids for treating chronic pain. And although it certainly helps some patients, it certainly doesn't help everybody. And in some patients, it actually harms them. And we'll talk more about that. But I think there's been an over-reliance on a single type of medication that carries a lot of risk.
And Rick, what do you think? How much of a problem do you think, or how much of a cause do you think that is?
I think chronic pain is a big issue. I think the insurance companies are most willing to pay for medication. They don't want to pay for other options for the management of chronic pain, such as physical therapy, acupuncture, even psychotherapy, cognitive behavioral therapy, help people accept what they have. So the easiest thing for the insurance company and the fastest thing in the perception of the patients is opioid pain medication. So I think that's part of it. My focus is not on chronic pain. I treat terminal pain, cancer pain, and narcotics, opioids are great drugs in that context. But it's becoming more difficult to treat patients with terminal and cancer pain because of the push on the chronic pain side. The patients and the families are somewhat less willing to accept the medications, take them as directed, and the doctors are feeling a very strong push not to use them.
I think Rick brings up a good point, and that is the distinction between different types of pain. And acute pain, which is after an injury, is a symptom, and it's there for a reason, so that we stop walking on the injured leg and allows it to heal. And absolutely, opioids are wonderful medications for acute pain, and that symptom will resolve or get better, and you won't need the opioid anymore. What I'm talking about is chronic pain, which is much more like a chronic disease. And it doesn't usually get better with a medication alone. And all of the things that Rick mentioned in terms of physical therapy and massage therapy and behavioral kind of counseling types of therapies, all working together are a much better approach to treating chronic pain. And then you've got the type of pain where people are really reaching the end of their life. And opioids are absolutely necessary in keeping people comfortable during that later stage of life. So I think we really need to make those distinctions.
And so one of the things that I hear immediately in this conversation is that we need to partner with our patients, that we need to be engaged together to figure out what is the disease we're treating, what is the best treatment, and when opioids are the best treatment, to think about how we're going to use them, and when they're not the best treatment, to think about what else we can do. That we shouldn't be afraid of one of our tools, but we shouldn't just fall into it, whether we're driven by insurance decisions or people's prejudice because of the news. We should use everything we have. How big a problem do we think that addiction and overdose is now compared to 20 years ago?
It's a huge problem. It really is. And, trying to understand that problem, is it patients with chronic pain or patients with pain that are getting prescribed opioids that are all becoming addicted? And not necessarily. There are lots of individuals out there who don't have pain, who get access to these medications through the medicine cabinet or what have you, who experiment with them and develop subsequent addiction. So it's not all about patients with chronic pain who are prescribed these medications. Now, clearly, some patients who are prescribed these medications for the right reason subsequently develop problems. And really, I think it's up to the patient to acknowledge that they're having some other issues, other problems, losing control of the medication, using more than prescribed. But it's also up to us as their caretaker, their primary care doctor, their physician, to see these types of worrisome behaviors and act upon them and say, I think you have terrible pain and I'm prescribing this medication, but I think you've developed a new problem.
And so there's some discussion that patients may be afraid to talk either about their worries about the medication, about not taking it, or about taking more of it. Are there other reasons that people misuse drugs than just they're addicted?
Well, I think in our society we're very focused on medication. You come in with a sore throat and you expect antibiotics, but maybe that's not indicated. And so I think there is an over-reliance on medications. And I think there is a feeling that if they're not getting adequate relief, it's because they're not taking enough. And our society is very lax about taking extra pills to treat symptoms. And in this case, it can be very, very dangerous. It could actually be life-threatening because we know that people are overdosing on these medications or these drugs that are out there unintentionally. These are not suicides. People are actually taking extra, and it's causing their breathing to stop or causing them to actually, lose consciousness. And these are all possibilities with these medications. So, one message that I would really want to get out there is take the medication exactly as prescribed. And before you leave the doctor's office, make sure you understand what those instructions are.
And Rick, do you ever feel like you see people who come to you or come forward with medications who are getting, for example, getting worse and might need more medication?
Oh, all the time. I treat pain with radiation, which is a good treatment for pain, especially bone pain from cancer. And so I often stop more I say I stop more narcotics than I start. But I not infrequently see patients who have nowhere near enough medication, who need sustained release medication so that they're not waking up in the middle of the night, they're getting the night's sleep they need, and they need more breakthrough medication. It's critically important to keep the patients comfortable enough that they can sleep, keep their caregivers comfortable, aware that the patient's going to sleep through the night so that they can get their sleep. So I think it is very common for cancer patients not to have enough pain medication prescribed. And I frequently will increase or start sustained release medication on a patient who's been on a short-acting medication for some time, but just is not getting enough relief.
So not to sound like I'm a one-beat drummer, but here again we're in the communication moment,
right,
where on the one hand we don't want to overtake simply because it didn't completely resolve the pain, or because there's some other benefit that comes from it, some buzz. And on the other hand, we don't want to undertreat. And the only way we're going to be able to manage either of those things is by being able to be really open, our patients with us and us honest with them about our worries on both sides, because they're both a form of suffering. Right. One of them, the more traditional pain suffering, and the other, you know, the terrible, terrible worry about opiates.
And I want to make a distinction between physical dependence and addiction. And patients get physically addicted to opioid medication much more easily than addicted. And patients who are physically dependent may have issues with needing the medication to prevent withdrawal, but don't do all the behaviors that we think of as addiction, and it doesn't interfere with their quality of life. And many of my patients are in terrible fear of being addicted, and it's a very delicate balance.
I also want to just add something that came to mind when you were talking about the interaction between patients and physicians, and I think there's a lot of issues around trust. And I have patients when I say, you know, what is your pain on a scale of 0 to 10, and they say 20. And why do they feel the need to exaggerate that score to me? And it's really, I think, to impress upon me how much they're suffering. And so that tells me a lot of information that, boy, I need to take a few steps back here and re-engage them in a conversation about how I absolutely believe that their pain is terrible and that they're suffering and that we need to work together. And then there's a lot of fear among physicians about addiction. And there was a study that was done in Massachusetts where they asked doctors in the community, you know, what prevents you from prescribing this medication for chronic pain? And 90% said they fear addiction. So they fear that they're going to make their patients addicted on these medications, and it's an exaggerated fear, but it does happen, and it's hard to predict who's going to run into problems and who isn't. So I think there's a trust issue on both sides, and there's fear of this medication as a tool around treating pain.
And this fear actually, in my experience, clearly extends to physicians being afraid to give cancer patients adequate medication. The other thing is they're afraid to give adequate medication to control acute pain. And we know that controlling acute pain can prevent the development of chronic pain, which many patients don't realize. Yeah. And so they'll have a broken bone, and they refuse to take enough pain medication to control the pain, and then the brain gets into a cycle where it keeps perceiving that pain even when the bone is healed, and that becomes chronic pain.
So I'm going to move us a little to maybe the most practical moment we'll get, which is to think about safety once the medication gets into people's houses. And I'm going to start by telling a story of one of my young addicted patients who got addicted by taking some of the medication that his mother had gotten for her terminal cancer. And he was treating a pain he had that was not a pain it was appropriate for. So I think I'd like to talk just for a minute about two things. One, safe management of opioids in the household. And two, disposal when they're no longer needed. Do either of you have opinions about how we do that?
Right. I mean, I think you need to be careful in leaving these types of, opioids in medicine cabinets where people can access them. If you have adolescents or or people visiting, you're certainly at risk of people taking these medications, and that is probably the number one way that people who misuse these that are not prescribed to them get them. They get them from medicine cabinets, and so I think people also need to be responsible in disposing of them when they no longer need them. And I completely understand some patients' reluctance, because they're fearful that if they do have a painful episode sometime later on, they'd like to have these available, and they may have trouble getting them from their physician. And so I understand that, but I think we all really need to play a role in this, and that is to protect these medications at home and get rid of them through take-back programs, through police stations have boxes that you can deposit them in, and I think we all have a role in keeping these medications safe.
And that means basically the medications need to be in lock boxes. And they need to be in lock boxes both for the prevention of somebody taking them from your medicine chest, but also to protect the patient themselves from getting confused in the middle of the night. So there needs to be a little bit of medication out in case it's needed in the middle of the night. But the big supply, if a patient has a month's supply and it's the beginning of the month, probably ought to be locked up. And then, I hate to say it, but when a patient passes away, somebody else has to take the responsibility of making sure that that medication gets taken to the police station and disposed of properly. And that's a weak spot in our system, both of those. The lockbox, I actually think the pharmacies should be issuing and the insurance companies should be paying for the lockboxes at the first narcotic distribution. And then there should be a system for making sure that drugs are secured after they're no longer needed.
So do you think that if we all collaborated in that way, we would change the diversion of what's happening? And do you have any feelings about how that diversion shades into other illicit drugs?
There was a very recent paper in the New England Journal of Medicine that reports that the steps that have been taken so far means that the rate of increase has dropped off as of 2011. This is wonderful news. It's early data, but at least it's getting better. And the rate of increase in Massachusetts was shocking. I think I saw somewhere where it was 79%. But we were 32nd in the rate of increase in the country. Lots of states are doubling or even tripling their rate, but we're in much better shape here on that issue. So I'm very pleased about that.
Yeah, I mean, I think your question is a complicated one, which is probably why there was a moment of silence, because it's really, there are lots of factors that play into this in terms of people who prescribe, physicians who are prescribing, doing it a little more carefully, a little more, not giving 30-day supplies when the pain is only going to last for a couple of days. But also I think there's more of a public awareness of the potential dangers of these medications, and maybe some more respect for the dangers of these medications. So they're using them a little more carefully.
And then I have a concern that as the supply of prescription opioid medications dries up, people who have developed a habit will shift to something that's more available and cheaper on the street, heroin, which is more dangerous than the prescription medications. And we have no idea what's in those drugs. So I have a concern about that too.
And that's actually happening, right? We're seeing increases in heroin use and increases of overdose deaths related to heroin as the overdoses from prescription drugs are going down.
So we know that one of the ways that we've reduced death has been by giving many of our firefighters and police officers Narcan when they're called to a scene. And now there's some discussion about us as physicians prescribing it in households where people have any worry. Do you have any opinions about that?
I do. I mean, I think it's a great innovation in terms of getting Narcan And the way this medication is given is through a nasal spray or nose spray, but there's also an injectable form, like an EpiPen when somebody has an allergy. But there's no reason we should hesitate in getting this medication out there, because it really does reverse an overdose and prevents death. And it's a completely safe medication. There's really no harm in it. And so I think teaching people, whether they're the patient getting the prescription, how to use it in case somebody in the household gets access to it and overdoses, or, as Rick had mentioned, if it's an older person who might be confused, who takes extra pills. I mean, again, you want to have this antidote, this way to prevent an overdose death, while you have an opportunity to call 911 and get, the emergency medicine or, ambulatory EMTs to come to your house and take over. But it really is life-saving.
We actually have a very good experience with Narcan in first responders in the city of Quincy, who've been doing this for a long time. And they've saved, I think it's now over 200 lives with this drug. And yet there are cities and towns in this state where the first responders don't have it. Every first responder in the state, in the country, should carry this all the time, even when they're off duty. And I think it should be in homes and available, because you never know if your grandchild or your child is using. I know everybody thinks their kid is a good kid, but they may be a good kid who's using and gets something else that puts them at risk. Or your neighbor may do it. And if you could save that life, there are only really two bad things that can happen with the use of Narcan. In the first place, if the patient was in pain and was taking the medication for pain, and you wake them up, the pain will come back, and that may be severe. And the second thing that can happen is the fact that Narcan works for a shorter period of time than most of the narcotics. And so you can save the life, and then if you don't get the patient to the emergency room fast enough, the patient can go back. You may need to give a second dose. And that brings up, we now have a Good Samaritan law in this state. You can call first responders and not be in fear that you will be arrested for being in the presence of drugs, because the government has decided it is more important to save lives than to arrest people for this. And I think that's a wonderful improvement.
Oh, absolutely. And this is the last time I'm going to say that. I also feel like people who want to come to their doctors and talk about getting a Narcan rescue kit, which all of our major insurers now will cover, so you can get a prescription for it, it fosters a different degree of conversation about the whole picture. What's the right medicine? If opioids are the right medicine, how are we going to store them? And what's our responsibility as a community to try to begin to save people's lives? So I feel like it's really a total win-win situation for us as we're starting to try to, reduce this. Because it's always funny to me, we talk about this as a public health problem, but this is about people's lives. People die from this. That's not a public health problem. That's a doctor-patient, community, and perception problem. I mean, finally, it's not about the pills or the powder, it's about the people. Mm-hmm. So we're coming to the end of our discussion, even though I would love to have you both here for another hour for us to poke at this. Dan, do you have any final comments?
I do. So I just want people, patients, to become less focused on the medication and more focused on getting better, and that will include what else is available in the setting that they're getting primary care, and that is physical therapy and acupuncture, and hopefully those services will start being covered by insurance companies. But I want to become less focused on the medication, and when they are prescribed medication, I want them to take it exactly as prescribed. Do not take extra tablets. Talk to your physician before you start taking any extra doses, because it can be lethal.
I agree with Dr. Alford. It's very important to take medication as prescribed. I think it's vitally important not to mix medications without discussing that with your doctor. There are times when the doctor intends you to mix drugs, and that's appropriate. And in addition, if you are using other substances, such as alcohol or marijuana, either medicinal or otherwise, that needs to be discussed with your doctor too. I did not used to ask marijuana, cocaine, heroin, hashish. I now ask every patient, every time, because it's important that I know what all they're taking. And there are interactions between drugs that can be can be lethal too, especially alcohol and benzodiazepines.
Oh my Lord.
So I think that's critically important. Don't mix, talk to your doctor, follow directions.
I just want to thank you both. I feel we've been incredibly fortunate. You know, Dr. Alfred, you're a real expert in addictions and in thinking about how to manage this. Dr. Peters, your experience with pain and with the other side, with making it clear that what we're trying to do here is really balance our capacity together as physicians with our patients to reduce suffering and to turn around this epidemic. I feel like you've both done a wonderful job, and I truly wish we had another hour and a half that I could poke and get more of your knowledge. Thanks. I want to say to the people who've been watching us that for more information about prescription drug abuse and to view past physician-focused programs on a variety of health topics, please visit our website at physicianfocus.org. I'm Dr. Barbara Herbert. I want to thank you for watching. I hope in the course of this we will save a life.
Prescription drugs are valuable medications and when taken under doctor's supervision provide effective treatment for many conditions. But the abuse of these powerful drugs has become a serious public health problem, resulting in the needless deaths of thousands of people.
Most people take medications responsibly, but more than 12 million Americans take prescription painkillers for non-medical reasons, many of them young people. Both physicians and patients can help to reduce the abuse of prescription drugs. Talk with your doctor about the risks and benefits of the medicines and explore different ways to treat pain.
The safe use of prescription drugs comes when physicians and patients work together to promote healing and good health. Medicines cure, heal, and relieve pain. Use them carefully, store them securely, and dispose of them properly when no longer needed. For more information, visit drugabuse.gov. I'm Dr. Richard Peters. The abuse of prescription medications has become a serious public health problem, especially among young people. Physicians are careful when prescribing these medicines, but the drugs are often diverted to people who use them without a doctor's prescription. In fact, more than 3 out of 4 people who misuse prescription pain medicines use drugs that are prescribed to someone else. If you take prescription medications, follow these steps to help us reduce the abuse of prescription drugs. Use medicines only as directed by your healthcare provider. Don't share prescriptions or use another person's medication. Keep medications in a secure place where others can't get at them. Don't mix drugs or use them with alcohol. And dispose of unused drugs properly and promptly at your local police department or through drug take-back programs. For more information, visit drugabuse.gov.